Very good evening to everyone and welcome to the third webinar of series of webinars hosted by Faculty of Dental Sciences, University of Peradeniya, Sri Lanka. I'm Dr. Sumudhu Madhavela from Faculty of Dental Sciences. Today we have an eminent oral and maxillofacial surgeon in the country with us, Professor Ajit Manjula Attygalla. Professor Manjula Attygalla is currently attached to the Department of Oral and Maxillofacial Surgery, Faculty of Dental Sciences, University of Peradeniya, Sri Lanka. He carries out his duty as an academician for 24 years. His maxillofacial surgery career too spans for more than 2.5 decades and currently works in the capacity of Chief Oral Cancer and Microvascular Reconstructive Surgeon in the team. He made his valuable contribution to the numerous academic forums nationally and internationally and received multiple awards. His interest is on oral cancer, orthodontic surgery and facial reconstruction. Also, he has co-authored multiple research publications. With that introduction, let me invite Professor Manjula Attygalla to deliver his presentation. He will be talking to us on challenges in mandibular reconstruction. Over to you, sir.
Thank you very much, Sumudhu, for your kind introduction. And hi and welcome to welcome all of you to this webinar series organized by the Faculty of Dental Sciences, University of Peradeniya. I think it's my duty first to thank the people who initiated this kind of activity, Professor Ruwan Jayasinghe and also Dr. Sumudhu Madhavela. And today I'll be discussing about the challenges in mandibular reconstruction, a case-based discussion.
Until the things get prepared, today Dr. Anushan Jayasinghe is co-hosting the event. Yes, thank you.
Okay, so I will start with my presentation, and in this presentation I hope to introduce the etiology of mandibular defects and why reconstruction of defects are important, and clinically oriented classification, which will be helpful in mandibular reconstruction, as well as anticipated goals of mandibular reconstruction, finally with the different options for reconstruction. And I hope to discuss several cases with you all of some interest in this regards. What you see here is a patient of ours with a mandibular defect, and by now you may have been reminded of this famous cartoon character Andy Gum. And this mandibular defect is something to do with the lower facial appearance, the aesthetics and the functions associated with it. So therefore, in recreating or sort of reconstructing this mandibular defect, what we hope to do is to recreate the form and function of the lower face in relation to the mandible. But in doing so, it is important for us to strike a balance between the etiology which is causing the condition as well as the amount of reconstruction we are going to achieve. So in another way, balance of biological life of the patient, such as the disease-free status with the surgery against getting back to the society, sending the patient back to the society. Then let me introduce, sort of discuss about some of the causes of mandibular defects. Trauma is one, and it may be simple comminuted fractures which may need some reconstruction, may range from gunshot injury to the blast injury. And in these cases, actually we have to think of the stability of the patient first, stabilizing the patient, and then getting rid of any infection, getting rid of devitalized tissue, and stabilizing the segments and the soft tissues until these targets are achieved. And then only secondarily that we have to go ahead with the reconstruction. One other cause is congenital anomalies. And as you can see here, this is one of the patients with hemifacial microsomia. In these patients, there can be varying degree of affection of the mandible. In here, there is facial asymmetry, and we need to start managing these cases from the childhood. And the aim is to reduce the defect itself, as well as developing secondary deformities in these patients. So in that, we might have to use different techniques, for example, osteodistraction combined with other normal reconstructive procedures in doing so. Another cause is actually locally or aggressive or benign odontogenic tumors, which is very common in the practice of maxillofacial surgeons. But what I feel is that we need to be a little conservative in managing these conditions. But when necessary, you have to be aggressive as well. For example, if it's a tumor, locally aggressive tumor such as the common one, amyloblastoma, in the posterior ramus going into the soft tissues, then you have to be aggressive. But on the other hand, we have been practicing things like dredging, which helps us to control the disease without causing much destructive treatment in these cases, because this afflicted group is a younger group of patients. Therefore, we might have to think of that, and when we need to reconstruct, we have to think of their quality of life and give the maximum as well. Malignancies affecting the lower jaw we see day to day, and in Sri Lanka, the commonest cancer in males is oral cancer, and they come in advanced stage, and it is necessary to remove both soft and hard tissues with their concerned problems, resulting problems as well. So therefore, here we have to strike a balance between to which extent we have to have a disease-free excision, sort of marginal clearance. On the other hand, with that, to get the maximum reconstruction, keeping in mind that quick healing, etc., is necessary to enabling the patient to undergo adjuvant treatment. In case of pediatric tumors, there is a different dimension coming into that because such as the blood loss and the long duration, which is the patient might get exposed to hypothermia. All these things needs to be controlled while getting the radical resection of the tumor. In that case, we can use the growth. We have to consider about things like growth in children to our advantage as well. Another cause is infections. Conditions like osteomyelitis, osteoradionecrosis lead to mandibular destruction. So may need reconstruction to give quality of life for these kind of patients. So in that case, it is necessary to assess the problem properly and use conditions, investigations such as bone scan, which might give certain accuracy in delineating the affected part. So free flaps invariably gives very good results in these conditions. Another common, another condition that is seen by us is this ankylosis of the TM joint, which is very difficult to deal with, and we need to employ whatever different techniques, stage process to get these patients to a good condition. A reconstructive surgeon should have an understanding of the role of the mandible, or the condition that mandible is contributing to the orofacial form and function. For example, it gives the lower face height, projection, and width. I use this slide to highlight the importance of soft tissue reconstruction. This gentleman, the patient, was referred to us for reconstruction of the mandibles. He is a bomb victim. Much of the anterior mandible was destroyed at that time with some associated soft tissues, and it was patient was sent to me with the reconstruction of that soft tissue defect only with the forehead flap. So as there was enough tissue at that time, the soft tissues, we reconstructed the mandible with a non-vascularized graft and got the continuity. But as you can see in the first picture, the lip function is aesthetics and also function is not good. But we were able to recreate to a certain degree the lower lip by using a palmaris longus tendon and the radial forearm flap, pre-flap, which gave a reasonably functional lip. But as you can see, there is a slight, there is color mismatch. So therefore, it is important for us to think of not just replacing bone, but creating a holistic reconstruction with the aim of reproducing the form and the function as well. Now, in thinking of defects, it's good if we can have a classification for mandibular defects. With this regard, I thought that classification by Cordero is important for a reconstructive surgeon. In that, there are 3 types. Type 1 is anterior mandibular defect plus 1 or 2 symphysial involvement. Type 2 involves the lateral defect together with the body, angle, and the ramus involvement, maybe with the condyle or without the condyle. Type 3 is actually having 1 or 2 components of the body, angle, or part of the ramus. So that is the bony classification, but there's another aspect to it in the classification, soft tissue. More importantly, he has classified soft tissue defect into 4 categories, with no soft tissue defect or with an intraoral lining or mucosal defect. Thirdly, skin external soft tissue defect. And finally, through and through defect. So combining all these, there is a very good array of different defect types described, which helps the reconstructive surgeon to think of whether to use a single flap, double flap, with a microvascular flap or a non-vascularized graft to decide. This helps so much. So therefore, I think this classification is a good one. In thinking of goals of mandibular reconstruction, I consider that quick primer healing is of much importance, because we have seen cases with bone breakdown and fistula formation, and that leads to problems such as issues in sending timely a patient to adjuvant treatment by a cancer patient, or we might lose a part of the bone or even the bone graft that we have placed. So therefore, quick primer healing should be considered. For that, actually, one important factor is nice soft tissue envelope. Then restoring the facial aesthetics and form. Obviously, as I mentioned, whether it's anterior defect or lateral defect, so depending on that, we need to consider many factors in achieving this thing. Finally, restoration of oromandibular function as early as possible. So with reconstruction, without much delay, we should be able to reconstruct and rehabilitate to achieve the mentioned functions as early as possible. Now, with all that, we can just list out some of the challenges in mandibular reconstruction. One is understanding the defect, understanding and dealing with the pathology, type of reconstruction, timing of reconstruction, reproducing the form of the mandible, and maintaining correct jaw relationship during reconstruction, and restoring oromandibular function. And the special issue I'm encountered is the reconstructing the pediatric mandible. At this stage, I would like to pose to you an opinion poll, because there are no rights and wrongs in most of these reconstructive principles. It depends on various factors, but depending on the expertise, resources. People use different techniques to achieve the same goal. Therefore, I would like to have the first poll, opinion poll. Sumudu, can we have the poll, please?
Yes, let me share the first poll.
Yes. So here, what methods do you use to maintain the occlusal relationship or the jaw relationship during mandibular reconstructive surgery? Whether it's dental splints, go for intermaxillary fixation, temporary fixation of maxilla and mandible with using a plate, or it's not important. So what your opinion will be valuable.
Shall we see the results, sir?
Yes, sure.
Yeah. Okay, the results are on screen now.
Yeah, actually, most of them go for intermaxillary fixation and dental splints. Temporary stabilization are used. Now, these are difficult commodities, some of the things for us, actually. Therefore, I think it's a good way of achieving with intermaxillary fixation. And this is, of course, the timing. There's no question. Immediate reconstruction will give the best opportunity to restore optimally aesthetics and functional results. What are the problems in delayed attempts? There would be soft tissue scarring, fibrosis, and contraction, which causes problems, and it will be very difficult to recreate the original situation for us to reconstruct. Therefore, I think immediate is the best, but I think there are so many factors limiting this opportunity, but we have to try and do as much as possible in the first time. Other thing is, what are the options we have for the mandibular reconstruction? Of course, although we talk about mandibular reconstruction, times we might not be able to put bone. So there is only soft tissue closure, allowing getting back the patient to whatever the necessary other treatment. Secondly, we can have a reconstruction plate to bridge the gap, maybe plus or minus a soft tissue covering. Then non-vascularized bone grafts are very useful. You have to be very judicious in using these non-vascularized grafts. Now the concept of critical size defect comes into play. It varies. I mean, roughly about 5 centimeter is the mark that is given. But there are newer sort of literature coming in showing that even bigger defects have been reconstructed with non-vascular grafts. But the gold standard in mandibular reconstruction is with vascularized grafts. So this has revolutionized. There are 4 things which, if I say, one is the microvascular technique. Secondly, the discovery of more and more composite flaps and vascularized flaps. And thirdly, the fixation with rigid fixation. And finally, dental rehabilitation with implants. So I think these options are available if we are thinking of mandibular reconstruction. Here, one of the cases that we had to use a plate actually, and a plate cannot be used in a sense of permanent sense in reconstruction, mostly in the long run give trouble. But if you think of as a permanent option, only what we can think of is a small size lateral segment of the mandible, but better to cover with a very good muscle flap. And however, in this patient with oral cancer, we had to use this method and we achieved a reasonable healing, but this may not happen always. So the soft tissue only reconstruction, there are very, very demanding situations. Now this patient is a cancer patient, which we have operated about 6 weeks back on this critical conditions. So we had to be doing the minimum possible condition and send the patient for adjuvant treatment. And problems like airway has to be a concern in such cases. This is a case reconstructed with a rib graft, non-vascularized rib graft, which was done about 25 years back as a trainee with my colleague, oncosurgeon, Dr. Kanishka De Silva, under Dr. Anthony Gabriel. Now, you can see that it was fixed with a wire, and there are two ways of doing it. You can incorporate it with the pec major muscle, but here we have separately taken it. But there is good healing. So, but the risks are there. So, in this kind of a situation, you need to fix the mandible, have the IMF even to get a good success. So, as I mentioned, vascularized grafts offer the best opportunity. And here, a case of ameloblastoma with a hemimandibulectomy and reconstructed with the vascularized graft. You can see a problem here. If you carefully look at it, the condyle is not in the perfect position. So these are the practical difficulties we come across. And if we have time, we can discuss about how to recreate the condyle. Let us have a look at reconstruction of the pediatric mandible. This is a case of golden horse syndrome, and you can see the obvious defect with the facial asymmetry. There is no condyle, right side condyle, as well as the right part of the right ramus is missing. So what we thought was to have the costochondral graft at this stage, because the growth from the child, as well as there is a possibility of growing the growth of the costochondral graft. So that has been used to prevent secondary problems developing in the maxilla, like the maxillary grant. But instead, it has to be staged 1, might have to do distraction, etc. later, and until his adulthood, there may be stage procedures to be done. This is a Pierre-Robin syndrome case with a tracheostomy done at birth because of the respiratory issues, and sent by the ENT surgeon to deal with the problem. So we thought of distracting the mandible, and we achieved a certain amount of distraction and awaiting weaning off of the tracheostomy. But there are cases like this. This is a mesenchymal chondrosarcoma, initial surgical, following initial surgery and radiotherapy, the chemotherapy, oncologist has referred to us. And at this stage, there is, as you can see, extensive involvement of the outside as well as the inside. So, Sumudhu, can we have the second opinion poll?
Yes.
We talked about the Cordros classification. What do you think? I mean, how can we classify this particular defect?
So I'm launching the poll.
Yeah.
Right, it's on the screen.
Yeah. Select the most appropriate classification category, anticipated defect. Type 1D, 2D, 1C. Type 1 is anterior, D is through and through. Type 2 is lateral, through and through. Can we have the results, Sundar?
Yes, sir. I'm sharing the results. So results are on the screen, sir.
Yeah, yeah. So, yeah, that's type 2D. Actually, there is, once you see, I will go to the next slide. You can see, if you can see my cursor, it involves the anterior mandible entirely up to the ramus on that side and part of the body. So it would move, and also the soft tissues involved here. So it's a not a very straightforward one, but I think it could be even 1D in that sense. So what we did was actually remove the soft tissue involvement with the margin as well as the bony part. And you can see that we haven't done a neck dissection in this case, but prepared the vessels for microvascular reconstruction. And we went ahead with this fibula graft. We do Doppler assessment of the skin pedal before scrubbing. And this is the excised specimen that you see. And we do specimen radiography sometimes when we have to have the marginal clearance assessment. And what I want to show you here is the very primitive ways of achieving the form of the mandible. This is an approximate sized mandible that we have different sizes of mandible, so we try and match one of those and bend the reconstructive plate accordingly. And you can see the osteotomized fibula graft and the reconstruction. As you can see, it's not the optimal thing, but we couldn't achieve the lip competence here because there was huge loss of tissue in the chin. And in that case, you need to bring another flap, but I was not happy to subject her to that much of morbidity. And we purposefully avoided a trachea, but secured the tongue to the mandible and had very careful observation with the anesthetist in the ICU until she was, we were happy about the airway. So these are the problems that we encounter in pediatric cases. The blood loss duration is long, and also the possibility of hypothermia, etc. So we have to overcome these challenges in doing these cases. So before proceeding, just we'll quickly go through 3 aspects of preoperative preparation. As we mentioned, it is very important to think of the cause. According to that, we might have to consider different things. For example, oncological evaluation, there's certain things to be considered. And also comorbidities. Pre-op dental evaluation is of utmost importance, and if not, might end up in osteoradionecrosis like. So then extensive resection, is it a must, or whether there are any less morbid or alternatives. Don't forget about the multidisciplinary team management. This is not a single-handed thing to be done. The oncologist, maybe depending on the etiology, and then definitely the anesthesiologist. And then if you think of dental rehabilitation, the prosthodontist, depending on the condition, there are so many people coming in, including the speech and language therapist as well. The second thing is the functional evaluation. We have to have an idea about the existing functional problems, maybe due to resection, previous irradiation, etc. And may also the anticipated defects due to the surgery. So it is important for us to think of aspiration risk, oral continence, etc., and assess speech and swallowing, and also nutritional status preoperatively and how to maintain that. So we have to have alternatives, suggestions, whether to go for a tracheostomy, peg feeding, etc. So all those things need to be evaluated, and how best flaps can be utilized to give the functions that we discussed earlier in the preoperative assessment. Then the reconstructive evaluation. We have talked about the defects, so extent of the hard tissue loss as well as the soft tissue loss, and how best are we going to recreate these combinations, whether we are going to use a composite free flap or a combination of 2 flaps. What kind of bone stock that we are thinking of is important. Other thing is the Doppler, the assessment of the reconstructive, the donor site. We use for fibula mostly Doppler, and if there's any issue, we go for CT angiography because it's not really available, and it sometimes we find delays in doing these things, but of course it's individual preference. I know in certain centers it's a gold standard that you do CT angiography for all cases. So these things we need to carefully decide, and the pre-op prosthodontic assessment and how to maintain the jaw relationships intraoperatively, and also the backup plans. The backup plan is very important because if a flap fails and there's no other option, both the surgeon and the patients will be in a very frustrating situation, and there's a life-threatening situation. And also when you think of soft tissue loss and replacement, we have to think of covering the great vessels, etc. as well. Here I would like to show use of microvascular flaps in mandibular reconstruction. One option is the deep circumflex iliac composite flap. We performed some of these cases, but our outcome was not that great compared to the fibula. The success rate was nearly about less than 80%. So the problems with this is actually the pedicle length is small, about 5 to 6 centimeters, as well as the diameter of the vessels are small. So it's a bit of a challenge, but the good side of it is actually it has a very good bone, maybe about up to 14 centimeters of very nice bone stock which is suitable for implant placement. On the other hand, fibula osteocutaneous flap is a very good flap that we regularly practice now based on the peroneal artery and vein, and it has a cutaneous component, and you can add bulk if you want with the soleus and muscle bulk. And segmental blood supply allows osteotomizing as well. And it can be used in challenging situations like this. This is a British priest who had a recurrence and underwent radiotherapy followed by again recurrence. So in reconstructing such a defect once operated, the bed is very poor quality, so it is best to have a vascularized flap to make sure that healing is uneventful. Other things to consider is actually osteotomizing while perfusing to reduce the ischemic period. So this helps immensely in doing that. So we osteotomize while the flap is still attached to the pedicle. In here, I would like to go for the third opinion, Paul Sumadu.
Yes, sir, I'm going to share it. I'm launching the poll, sir.
Yeah, thank you.
So it's on the screen.
Yeah. How would you achieve the form of the mandibular fibula repair? That is, how do you shape? Whether you use a wire or acrylic template based on a CT or XI specimen, by freehand, or use an average size mandible as a template, or you have the digital workup. So as again, we mentioned, depending on the resources, things might be different. So it's great for us to know how you all go ahead with this. So are we okay with that?
Yeah, yes, sir. So I'm going to share the results.
Thank you.
So it's on the screen.
Yeah, mostly it's use an average size mandible as a template to bend the plate, it seems, but all even, yes, I also agree at some stage we use freehand, but it's very difficult and we go wrong in most of the time. And digital workup gives the best result, but of course it's resource dependent. This is how one of the examples. What we do is we use a wire template bent, and we use the measurements as well. The distance between the cut ends from this distance, as well as the length of the mandible, and sometimes the distance from the canines to the edges as well. So combining all these, we can get a very close resemblance of in the osteotomized and neo-shaped mandible. I would like to share some of the cases of microvascular reconstruction now. And this is actually a patient who had a schwannoma and say about 8-9 years back, it was excised and reconstructed with a non-vascularized graft, but with time, you can see that the resorption of the graft, and the patient wanted reconstruction of the defect. I would like to have your opinion here regarding the reconstruction approaches as well as the reconstruction method as well as the approach in this case, and we can launch that poll.
And let me launch the poll. It's on the screen, sir.
Thank you. So whether it's an extraoral approach with a non-vascularized graft, extraoral approach with a vascularized tubular graft, or through and through approach with a non-vascularized graft. Yeah, I think we can go ahead.
Yes. So results are on the screen.
Yeah, I think all these approaches can be done. Definitely the extraoral approach will be preferred to prevent infection. So the fibula graft is also good. What we thought of is going ahead with a digital planning and then use extraoral approach because of several reasons. One is it's a large defect, it's a failed graft, and also we need to young patients, so we need to create the form as much as possible. Therefore, we went ahead with this customized plate formation with the cutting guide provided for the mandible actually. And you might wonder why we haven't included a condyle. So that is the issue that I would like to discuss later. And extraoral approach, you can see the remnant of the bone graft here, and we use the cutting guide to section and approximate. So the vascular section, we haven't used a fibula guide here because of the cost reasons as well. So and this is the pre and post-operative situation, fairly good reconstruction, but as again you can see here, it's not the ideal relationship, but it doesn't show here. Functionally, patient can open. Of course, there will be slight deviation as the rotation is not happening with this translation may not take place in these kind of situations. The next case is actually a second recorrection. This patient had a mucoepidermoid carcinoma of the mandible, and segmental resection has been done, and the segments were stabilized with a temporary plate, and the patient wanted reconstruction. So this, I want to highlight the digital use of digital planning. This is the 3D reconstruction and mirrored image, and it was collapsed, and we, the software engineer got the aligned, the segments aligned, and you can see it here clearly. Here we used a cutting guide as well. It's a 6 centimeter roughly length, and the cutting guide was exactly fitting and helpful, and it was very easy for us to. This is a combined case with my colleague, Dr. Nadina Jayasuriya. And you can see the fibula template fixed. In this case, actually, we haven't used implants, but if implants can be done. A lot of things get limited because of the cost. Actually, if this is the stage to fix implants, the customized implants. If you are doing with implants, and then you can osteotomize, and this is the final osteotomized segment fixed, and the final result. As it is immediate post-op, there is some swelling, and there may be little more muscle bulk which can revise later and get a good control. Before proceeding with other few cases, I would like to mention about few aspects of mandibular intraoperative aspects. So two-team approach will reduce the length, and be careful about these aspects, hypertension, etc. But you have to be careful during resection time. It's good to have hypertension, but when the anastomosis takes place, you have to have good pressure. And minimize flap ischemia, establish jaw relations, templates or digital planning, re-establish circulation and aid good perfusion, good oral closure and suction drains, etc. will help in the intraoral reconstruction. And also it's very important post-operative manage, careful post-operative monitoring of flap when you use microvascular flaps with a sense of urgency. We have to do that, and adoption of criteria for management for microvascular surgery. And don't forget about the feeding, airway aspects, and mobilization. With that, we move to the last two cases. This is one of the patients I did about 6 or 7 years ago. This teacher presented with a mandibular lesion, which was diagnosed as squamous cell carcinoma, and we had to repair it with fibula osteocutaneous flap, reconstructing the floor of the mouth as well as the mandible. But what happened later, she developed a small lesion few years later, second primary maybe, but she had already undergone radiotherapy, you can see that. And I couldn't take a chance, and we had to do wide resection, jeopardizing the reconstructed mandible as well. Part of any fractured, and there were a series of complications, and this is the result few months later. So she had a lot of problems in oral competence and the aesthetics, everything. So at this stage, again, shall we launch the final poll, Simple?
Yes, sir. It's on the screen, sir.
Yeah, thank you. So this is a very difficult situation. I would like to have your choice in selecting a method for reconstruction. The bone defect was about, say, around 4 to 5 centimeters. Whether it's a non-vascularized bone graft with a vascularized soft tissue, vascularized fibula with a skin paddle only, or vascularized fibula and a pedicled or vascularized soft tissue flap, or some other kind of thing like mesh tray with bone graft and soft tissue flap.
Shall we see the results, sir?
Please.
Yeah. The results are on the screen.
Yeah, so most have thought of vascularized fibula and a pedicled vascularized soft tissue flap. I agree, but it is a bit different what we went ahead with. We had to go ahead with a customized mesh tray. We thought of, in consultation with the patient due to several reasons. One is that patient was subjected to many surgeries, including a fibula flap, and therefore she was a bit concerned about it. And with this type of customized planning, we can recreate the form in a better way. So with all that, we thought of using the customized tray and a pedicled flap. That is the other thing you may not agree, but we went ahead with the pedicled flap, pec major flap covering the outer and inner defects. We have de-epithelialized the part of the pec major, and utilized. So this is after recreating the gap and releasing the soft tissues, graft, the mesh tray fixed, and the iliac crest bone graft chips placed with combined with the PRP, and then this is the result. So there is still aesthetic issues, asymmetry, but still from the situation she had, we have come across, I think, fairly okay. But there's a lot of risk in this kind of cases, but we had to take the challenge and do it in this case. So ideal would have been using two separate flaps if possible with the fibula flap. Post and pre and post comparison. Final case, it is just to highlight the dental rehabilitation following mandibular reconstruction. We are new to this digital planning. Actually, this case was done about another 5 years ago when extensive mandible ameloblastoma, we had to resect and reconstruct when there was no digital planning or anything. But I think you agree that it's a fairly good reconstruction in the case of the form and the function. And later she defaulted and didn't come for some time, but wanted implants later. So we had to graft it again. We once grafted, and again there was a delay and the graft got resolved. So we again had to go and place iliac crest graft. And there was, because of the long lag in without teeth, there was over-eruption, etc. The orthodontist helped us with the TADs, you can see, to a certain degree, arranging the teeth orthodontically and refashion the soft tissue and place implants. And she's awaiting the dental rehabilitation. With that, I would like to summarize what we discussed today. The mandible contributes for lower face aesthetics and associated essential functions. And many etiologies contribute for mandibular defects with different consequences to be considered in the reconstruction. Immediate reconstruction is the best, and mandibular defect could be complex, involving both hard and soft tissues, and creating a good soft tissue envelope is important. Careful planning with multidisciplinary involvement leads to good results. Free vascular grafts will be very useful in mandibular reconstruction, and reconstruction should be followed by rehabilitation for improved quality of life. Don't forget about the backup plans, which is sometimes maybe life-saving option. So with that, I would like to conclude, and I would like to acknowledge all the doctors who helped in these cases, as well as the patients, again, the software engineer who helped us with the digital planning. He may have joined already, I think. And also my thank goes to Anushan, who helped me with some of the aspects of the presentation as well. Thank you very much.
Thank you very much for that wonderful presentation, sir. We have a few questions, few live questions as well. So let me ask, before going into the other questions, let me ask one question, one doubt suddenly clicked on my mind. When we are reconstructing anterior defects and or posterior defect, I'm sure there are common problems we encounter.
Yes.
But if we take them separately, are there any separate problems pertaining to anterior defects and posterior defects?
Definitely. Anterior defects will lead to, especially the concern is the airway actually.
Yes.
The hypomandibular or the suprahyoid muscle suspension is at a stake. So therefore, swallowing, dysphagia problems, oral continence problems, as well as the airway problems with it there. So therefore, we need to, when we reconstruct, we need to recreate that in the anterior defects. Whereas in posterior defects, there will be collapse of the cheek and deviation of the mandible, especially in dentate patients. This is a real problem. So these two issues are different. Actually, when we reconstruct also, we have to think of a suitable amount of soft tissue in recreating those issues.
Okay. Thank you very much, sir. So we have a live question from Dr. Anwar Sadat. So, Dr. Anwar, can we have your question, please?
Hello.
Hello, Anwar.
Yeah, we can. Yeah.
Good evening, sir.
Good evening.
It's a great pleasure for me to hear you. It's a fantastic presentation. And my question is, do you follow the dressing in ameloblastoma only, or also in keratosis? This is my first question.
Yeah, actually, we now routinely we employ dredging, and many segmental resections we have avoided by using dredging. So actually, initially we didn't believe in this, but we're frank to say that I heard first from one of your Bangladeshi colleagues, Dr. Nadimul. So then many years later, that this came back, and we are very happy with the results. But there are concerns we have to be careful, because one question is whether there is repeated interventions, whether it leads to malignant transformation. There is only one case that we have in doubt, but that is also not after a long time. So what we do is we do frequent dredging, say every 3 months, and we don't go for years and years with the dredging. If most of the cases it will settle. If it doesn't settle, then we adopt the normal treatment procedure. And we usually do for ameloblastomas. Yes.
Oh, not for the keratosis.
No, keratosis, what we do is just decompression. We put a small diameter tube, and mostly it will settle. We don't have to go and repeatedly dredge in this.
What about the multilocular lesions, multilocular keratosis?
Definitely, with
follow the decompression.
Yeah, very rarely that there is a resistant one coming out with in case of keratosis. So we don't we make sure that all the locules are broken by the time that we place the tube and go on with the tube. But for ameloblastoma, of course, we go ahead with dredging.
Thank you so much.
Thank you very much, Dr. Anwar. So we have a few more questions. This question is from Dr. Sana Safar, and we have a similar question from Dr. Gayani Vasana also. So let me read the question.
Yes.
In a patient with oral squamous cell carcinoma,
yes,
for which we are planning segmental mandibular resection with immediate implant placement.
Yes.
What is the recommended time period after which radiation therapy can be performed? And Dr. Gayani adds to that, and how should we plan a radiotherapy if a patient needed after reconstruction with a graft? How long we should wait to start it?
I think now it's not possible for us to wait because of an implant if there is indication for radiation therapy, because that's what we discussed. I mean, we had to balance the biological life with the social life of the patient. So it's a critical thing. Now there are certain definitive indications for radiotherapy, post-operative radiotherapy. So in that case, if there's such an indication, I think we have to think of going ahead with radiotherapy. The recommended period is within 6 weeks. We have to provide. We have to subject the patient for radiotherapy. There are controversies in that, but I mean still the accepted, mostly accepted theory is that within 6 weeks we have to try and go ahead with the radiotherapy. Now, I don't think this is an issue in case of vascularized flaps. But in case of non-vascularized flaps, it is an issue. So one thing, if we have to subject the patient for radiotherapy, vascularized flaps, we don't have to be concerned about it, and we have to go ahead immediately within that particular period. But non-vascularized flaps, even implant doesn't come the first thing to be concerned. It is the survival of the patient. So it's a difficult question to answer, but I think in the case of vascularized flaps, we can go ahead with radiotherapy without much fear about having a problem.
Okay. Thank you very much, sir. Anushan, can we have the next question?
Yeah, good evening, everyone. I will ask the second question. It is also from Sana Safar. Sir, he's asking about your experience with double barrel technique using free fibulas.
Yeah. Yeah, actually, we have attempted twice, and one was not successful. What we do is we remove about 2 centimeters or pedicle, the bone, and double barrel it. So it should be that the pedicle should be near the recipient vessel. So anastomosis, it's become easier. So you don't have to have the full length double barreled. What we want is the area where the implants are placed, that area to be double barreled. So it's difficult when you turn it, there is a possibility of kinking. So one part of the flap was failed because of that. So you have to remove adequate amount of bone, making sure that when you double barrel it, there won't be much kinking, compromising the blood supply.
Okay. Thank you very much, sir. So we have another question from Dr. Gayatri. Sir, can you explain the use of different reconstruction conceptual frameworks in the mandibular reconstruction, like reconstruction ladder or reconstruction supermarket?
Yeah, actually, reconstruction ladder nowadays it's going a bit out of date, like, because it's now accepted that, especially in cancer patient, it's the first attempt, and you give the maximum quality of life. Even the patient is going to live for a short period, you try to give the quality of life back. So in that case, you, rather than trying step by step from the simplest option, nowadays what we do is, depending on the suitability of the patient, to even go for the best one. So elevator method rather than the ladder, reconstruction ladder. So we go to the different level and try and give the option. So I don't think in mandibular reconstruction we have to think of the reconstruction ladder, but we have to think of the factors that we have discussed and give the try and restore form and function in as early as possible in one go.
Thank you very much, sir.
Okay, so I will ask the next question. It is from Nelumi Abesing. She is asking about the donor site, fibula donor site. Does the resection part of the fibula compromise the use of the leg?
No, because you have to be careful, because some functions can get affected, but there won't be problem as such. If you leave good enough bone, that is about maybe 8 centimeters of bone on both ends, the joint function will not be affected. Therefore, there is no affection of because of the harvest of the graft.
Okay.
Thank you.
Thank you very much, sir. So we have another question from Dr. Harendra Jinadasa. So what is your opinion in immediate reconstruction of mandible in osteosarcoma and a wings tumor? Do we want to wait?
That's what I was trying to explain. For example, in that child, now that much of extensive tumor, the prognosis will be very poor. But can we leave a child with 2 mandibular segments hanging and having all the difficulties in having food and the quality of life. Therefore, I think not in a very irrational way, but in a rational way with the consent of the patient, we have to think of restoring quality of life. So that is the norm now, actually. You have to give back the quality of life. You know, in squamous cell carcinoma also that the prognosis hasn't improved much, but we are trying to give the quality of life. It's similarly in osteosarcomas, we have to think of adequate resection and then immediate reconstruction to give back the quality of life as much as possible.
Okay, thank you, sir. The next question is from our good friend Sankar Pagamge, and he is thanking you for the excellent lecture. And he wants to know what are the methods of condyle reconstruction in hemimandibular?
Yes, that is, we couldn't discuss much about it. There are a few ways. One is with no reconstruction, that you wrap some fascia around it or put a costal component to it and accept. So there is a bit of chance of ankylosis, but we haven't come across because we have this experience mostly. Second option is to use the autotransplant of, if there's a condyle left, a small part even, this can be used in the reconstruction of the condyle. Thirdly, whether to use prosthetic TM joint as well. Now, the case which I showed, even we designed with the condyle, but then I was a little concerned because as there is no counterpart in the base of the glenoid fossa region, so then whether it causes with function, erosion and problems. So because we are new to digital planning and things, and that is one factor. The cost factor also, because when we print with titanium, that much of addition will cost a huge amount. So to answer your question, one is use the prosthetic TM joint addition, or neocondyle, the autotransplantation, or just leave it covering with some soft tissue or cartilage. The best results, they most have come up with the autotransplantation. But the problem is, as you have seen, it is difficult to keep it in the glenoid fossa even when we do that. So there some have put wires and secured as well. So, but it's a bit of a difficult thing. But digital planning will help in avoiding these kind of problems.
Okay. Thank you, sir.
Thank you very much, sir. So we have another question from anonymous attendee. Sir, not relevant to this discussion.
Yeah.
Can we do full face transplant in Sri Lanka?
It's a difficult thing to say. I mean, there's no. I mean, it has to be a team. You see, I mean, a single person cannot. I mean, one has to realize fully the challenges involved in such a procedure. So it's there should be a team with that intent. I mean, with that type of aim and trained in certain aspects. So doing one or two reconstructions will not just simply be able to take that challenge in a confident way. I'm saying that you can attempt, but I mean, there are so many challenges, not only the anastomosis, but other areas of management. So we have to have a team. I think that's a very good question and very good thing to think of. But then we have to have a teamwork from many aspects. Many specialists should come in. It's not only the surgery, as well as facilities and other management strategies. So yes, we have the capability of doing it, but we don't have the infrastructure, or I don't think still anybody has thought in that line up to now. So we should aim for that.
Thank you very much, sir.
So the next question is from Loshan Senaratna. He's asking about a class 1 mandibular defect, anterior defect, whether it is possible to use distraction osteogenesis to reconstruct the mandible, anterior defect of the mandible with 7 centimeters. Can we go for distraction osteogenesis?
Yeah. Now, it is not distraction alone. It is called bone transplantation. Yeah, but the problem is the curvature. Now, there are, I mean, technically it may be possible, but then you have to have a customized plan and all that. So the cost and everything, whether it's worth doing it, and when you have other options. So that's the thing. It's not impossible, but I don't think it's a viable option when you compare with the other options available. But for a straight defect, of course, that may be an option.
And also he's asking about the control of the vectors. If you are going for the bone transport, how to control the vector?
That's what I mean. It's the digital. Definitely, there should be a customized gadget for that and control the vector. Otherwise, I mean, it will not work. So it's the technical part rather than the surgical this thing. So we need to plan it and customly make the transporter. So that will be possible in that case.
Thank you, sir.
Thank you very much, sir. So we have another question. So first of all, he's thanking you for your wonderful lecture. And after mandibular reconstruction, how about the speech of the patient? Do the patient will get back speech as usual, or is there any difference?
There should be much difference because speech is, there is so many factors coming into play, the teeth, the soft tissues, etc. So therefore, if we recreate all that, there shouldn't be any problem with the speech. We haven't come across. I mean, if you recreate, if you say if there's no teeth, the lip will collapse and the pronunciation could be different. So like that, you have to think of each and every aspect and do it and provide the necessary amount of soft tissue for the movement to produce sounds. So in that case, there is no issue as such. But of course, with the reconstructions with using the pedicle flaps, such as the pec major for the soft tissue component, there is dragging and there can be changes. But if you are really concerned, we should be able to recreate, and speech will not going to be much affected.
Thank you very much, sir. Anusha?
Then there is another question from Isuru Priyankara.
Yes.
It is whether the reattachment of muscles is possible after bone graft for anterior mandible.
Yes, it is possible, and it should be done as a routine. So the reattachment can be done in various ways, but what we do is we can drill a hole and sort of we can get the tendon, not the soft part of the muscle, but tendinous areas attached to the mandible, or even through and through the reconstructed bone. We can do that. So that is important to do that. If there's any soft tissue part left in the area, we can attach to the soft tissues as well, but it is important to attach it to the bone as well. So it can be done, it should be done to make sure the tongue and the floor of the mouth area is functional.
Okay, thank you very much, sir. So we have two questions. Okay, both carries the same both directs into the same area. So Dr. Zana Safar is asking, what is your experience in double barrel technique of fibula flap? We had a similar question from Dr. Muhammad as well.
Yeah. To be frank, I haven't had got much experience. We have tried about 2 cases, and one there was partial failure. So you had to do it in a careful way, but it can be done. and where necessary, where the dental rehabilitation is planned, it has to be done. But if you do it carefully, it won't give much of a problem. But you have to consider pre-plan it. The harvesting of the flap should be large enough so you can sacrifice a part of the bone, still get the pedicle turned without compromising the flap. Like that, you have to think about it beforehand, plan and do it. So especially with digital planning, there should be easier reconstruction by that. Yes.
Okay. Thank you very much, sir. So that ends the question and answer session as well. And that remarks the conclusion of the session. And thank you very much, everyone, for staying connected. Hope you had a fruitful session. Let me once again thank Professor Mandibular Attygalla for his contribution to this session, and Dr. Anushan Jayasinghe, thank you very much for co-hosting the event today. And this is a kind reminder before we wind up. The webinar will follow up with an email, and please follow the link and submit your feedback for further improvements. Please stay connected, and we will be having our next webinar on 12th Tuesday. So that will be on oral pigmentation. Hope to see you there. Thank you very much. So thank you.